Good evening. Welcome to today's workshop being held by KIMSWAY Hospital on understanding obesity and its management. Obesity has become a major public health concern worldwide, affecting people of all ages and socioeconomic status. It is associated with a wide range of chronic diseases and health complications, including diabetes, heart diseases, stroke, just to name a few. While there is no single solution to tackling this complex issue, education and awareness are key to preventing and managing obesity. That is why we are pleased to introduce this workshop on understanding obesity and its management. This workshop is designed to provide its participants with a comprehensive understanding of the causes, consequences, and management. Through interactive sessions and expert-led discussions, participants will gain insights into the latest research and evidence-based strategies for preventing and managing obesity. Whether you are a healthcare professional, a policymaker, or simply someone who's interested in learning about obesity, this workshop is for you. Here at KIMSWAY Hospital, we believe in adopting a holistic approach towards tackling obesity with a comprehensive and interactive team of experts from all fields of health. For this purpose, we have an initiative known as SkinFitter, a unique weight loss program that is seeing great success with lifestyle modification and providing personalized plans for every individual. Now, without further ado, I would like to now welcome Dr. Sushil Lohiya. He's a renowned laparoscopic and bariatric surgeon in central India. Born and brought up in Nagpur, trained in surgery and advanced laparoscopy at Mumbai and various national and international centers of great reputation. He has served patients in Nagpur and central India through various institutes and has a very good rapport. Dr. Sushil Lohiya has performed hundreds of complicated surgeries since a very young age and produced consistently good results. His motto is to improve quality of life by compassionate care with precision. Hence, he took the initiative of finding a solution to fighting obesity through a scientific approach and is also the founder of KinFitter. Welcome, sir.
Thank you, Harish. So today, we all know what is obesity broadly, but what exactly and why people become obese, and why few people who eat less become obese, even if few doesn't become obese in spite of eating more than what other people eat. Is the workout reason? Is the diet a reason? What exactly is make somebody go obese and somebody still remain lean? So we all know कि obesity क्या है? Basically, the more fat accumulated inside the body is the most simple definition of obesity. But if you see it medically, it is a chronic, मतलब long term disease है, relapsing जो बार बार होती है और धीरे धीरे gradually progress होती है. That is a chronic relapsing progressive disease and incidence यानी मोटापे का incidence has risen 13% globally in last year. How to measure? There are multiple way of measuring obesity, but the most simple is of course the weight, and it is categorized by your height and weight in kg and height in meter. अगर आपने अपने weight को height in meter square से divide किया तो एक BMI का range आता है. 18 to 25 is considered as normal range. जैसे जैसे आप 25 के ऊपर जाने लगते हैं तो it is called overweight. And when you go more than 30 BMI, it is called obesity. Obesity का classification होता है class 1, class 2, class 3. जब ये 30 से 35, 35 से 40 और 40 से ऊपर जाती है तो उसको severely morbid obese बोलते हैं. Globally अगर हम देखेंगे तो 1.9 billion adults are overweight. 39% of population over 18 years is obese. And in India ranks almost third in obesity after USA and China. Or in childhood obesity has almost tripled in last few decades. So what about obesity? आप में से यहाँ कितने लोग ये मानते हैं कि obesity मतलब ज़्यादा खाना और कम एक्टिविटी करना? किसी को ऐसा लगता है कि obesity मतलब या तो obese लोग ज़्यादा खाते हैं और काम नहीं करते, आलसी होते हैं, बिल्कुल हिलते नहीं हैं, इसीलिए मोटापे होते हैं? Good. So that is not, it is like that. Obesity is just the sign. It is not the disease जिसको हम obesity करते हैं, fat. This is just the sign patient gaining weight. Weight is just the sign that there is something wrong inside the abdomen. जैसे हम एडेमा देखते हैं, अगर किसी पेशेंट को बहुत ज़्यादा एडेमा आता है, पैरों में सूजन आती है, तो हम ये थोड़ी बोलते हैं कि ज़्यादा पानी पी रहा है और यूरिन को बार बार नहीं जा रहा, उसको ऐसा थोड़ी बोलते हैं तू कम पानी पी और यूरिन को ज़्यादा जा। वो उसके हाथ में नहीं है, क्योंकि बॉडी में कुछ ऐसे सिस्टम है जो हमारे बॉडी का वाटर बैलेंस मेंटेन करते हैं। आप ज़्यादा पानी पी के भी पानी ज़्यादा जमा नहीं कर सकते और कम पानी पी के भी नहीं मेंटेन कर सकते। तो ओबेसिटी दो देखने में ऐसा लगता है कि सिर्फ इंटेक एक तराजू है जहाँ इंटेक और आउटपुट पे डिपेंडेंट है, लेकिन देयर आर लॉट ऑफ थिंग विच इज डिपेंड दिस इंटेक एंड आउटपुट इज डिपेंडेंट ऑन आपका हंगर, सटाइटी, आपका न्यूट्रिशन एब्जॉर्ब करने का कैपेसिटी, एक्सपेंडिचर, आपका मेटाबॉलिक रेट, थर्मोजेनेसिस बॉडी की हीट प्रोड्यूसिंग कैपेसिटी, एक्सरसाइज, और बिना एक्सरसाइज किए बॉडी में जो थर्मोजेनेसिस होता है उसको नीट बोलते हैं, नीट। सो ओबेसिटी इज बेसिकली जैसे डायबिटीज, हाइपरटेंशन, एक जेनेटिक बीमारियां हमें पता है कि परिवार में चलती है। अगर माँ बाप को डायबिटीज है तो बच्चे को डायबिटीज होगा, परिवार में किसी को हार्ट का डिसीज है या हाइपरटेंशन है तो उसको हाइपरटेंशन होगा। उसी तरह ओबेसिटी भी एक जेनेटिक डिसीज है। व्हाट इज इपीजेनेटिक्स? इपीजेनेटिक्स मतलब अगर जेनेटिक आपको प्रीडिस्पोजिशन है और आपको एक एनवायरनमेंट उस बीमारी को मैनिफेस्ट करने के लिए मिलता है तो वो बीमारी मैनिफेस्ट होती है, अदरवाइज वो जीन मैनिफेस्ट नहीं होते। दैट इज कॉल्ड इपीजेनेटिक्स। लाइफस्टाइल डेफिनेटली, आपका लिविंग सिचुएशन, मॉनेटरी सिचुएशन, सोशल सिचुएशन, कल्चरल बैकग्राउंड, ये सब चीज़ें मैटर करती है। एंड इट्स हेट्रोजीनियस। जैसे मैंने कहा, एक ही परिवार में कोई मोटा हो सकता है, कोई मोटा नहीं हो सकता, या एक जैसा खाना खाने वाले कोई ज़्यादा वजन गेन करता है, कोई कम वजन गेन करता है। इट्स हेट्रोजीनियस डिसऑर्डर। इपीजेनेटिक्स जैसे मैंने समझाया, एनवायरनमेंट और जेनेटिक के मैनिफेस्ट करने से होता है। देयर आर 100+ genes which are identified which are directly related to obesity. This is the simple illustration of a cycle which controls your hunger and satiety. हमारे बॉडी में दो टाइप की साइकिल्स रन करती है जो ब्रेन और पेरिफेरल हार्मोन्स लाइक हमारा गट, इंटेस्टाइन, लीवर, पैनक्रियाज कंट्रोल करते हैं। और इस साइकिल में एनोरेक्सोजेनिक और हंगर साइकिल है। लेप्टिन इज द हार्मोन जो हमारे बॉडी में एडिपोज टिश्यूज सिक्रीट करता है। जब लेप्टिन का कॉन्सेंट्रेशन बॉडी में बढ़ता है तो हमें सटाइटी की फीलिंग आती है, ब्रेन को हंगर कम लगता है, एनोरेक्सोजेनिक साइकिल बोलते हैं। एंड जब हमारे बॉडी में फैट कम होता है तो बॉडी में ग्रेलिन करके बढ़ता है जिससे भूख लगती है और हंगर बढ़ता है। इसको ऑक्सीरोजेनिक साइकिल बोलते हैं। और अनफॉर्चुनेटली हमारे ब्रेन को भूख लगने वाली साइकिल बहुत स्ट्रांग है, लेकिन सटाइटी वाली साइकिल बहुत इजीली ओवरराइडेबल है। अगर हमने खाना खाने के बाद किसी ने हमको बोला कि एक डेजर्ट है जो हमारे यहाँ पसंद की डिश है, तो हम इजीली खा पाते हैं क्योंकि हमारे बॉडी की सटाइटी साइकिल जो है उसको ओवरराइड करना बहुत इजी है। ये नेचुरल इवोल्यूशन है, क्योंकि हमारे ब्रेन को ऐसा सिखाया गया है कि जब हंटिंग करते थे खाना मिले तो जमा कर लेने का, जब नहीं मिलेगा तब यूज़ करेंगे। इसीलिए ये साइकिल ओवरराइडेबल है। हंगर का साइकिल को ओवरराइड करना थोड़ा मुश्किल होता है। जब आपको भूख लगती है तब आप खाना ढूंढते हो या आप चिड़चिड़े हो जाते हो, तो हंगर के साइकिल को ओवरराइड करना नेटिवली थोड़ा सा मुश्किल होता है। और दे आर मल्टीपल वेज। सटाइटी के लिए कुछ हार्मोन सेंट्रल होते हैं जैसे मैंने बताया, कुछ हार्मोन पेरिफेरल होते हैं जो इंटेस्टाइन से सिक्रीट होते हैं लाइक लेप्टिन एंड ग्रेलिन। ऑल्सो दे आर समथिंग कॉल्ड GLP-1 एंड ऑल अदर हार्मोन्स विच अफेक्ट योर हंगर एंड सटाइटी। सो जब आप ओबेसिटी की बात करते हैं तो आपको तीन मेन चीज़ें ध्यान में रखनी होती है। इज द पेशेंट is metabolizing his fat or energy slowly? Why the patient is not burning the fat? Second, is there weight gain due to increase intake? ये ज़्यादा खा रहा है क्या? जैसे सोशो कल्चरल फैक्टर, हमारे यहाँ प्रॉस्पेरिटी मतलब गणपति पप्पा, एवरीबडी नो ही हैज़ अ बिग बेली। सो हमारे यहाँ जब बेली बढ़ जाती है तो वी कंसिडर दिस एज अ प्रॉस्पेरस। सो वी आर सोशली कल्चरली अट्यून टू सी ओबीस पेशेंट एज हेल्दी पेशेंट। आपके घर में अगर कोई हेल्दी मोटा है तो उसको मोटा नहीं बोलेंगे, बीमार नहीं बोलेंगे, उसको हेल्दी बोलेंगे। अगर आपका वजन नहीं बढ़ता, आप लीन हो, तो आपको दुबला बोलते हैं, मतलब आपका बल कम है। सो हमारा सोशो कल्चरल as perception of obesity is considered as healthy. That is what is our society is. Second, a way of showing love in lot of culture is by food. Unless they make you eat two more bites, one more roti, your mother, your relative, or guest, or host doesn't feel satisfied and doesn't feel they have shown their affection enough. So all these social factors that you have to understand. Then there are the factors like depression, anxiety, seeing TV and mobile while eating, and there are some psychiatric disorder. And आपको ये भी assess करना है कि पेशेंट क्यों नहीं कर पा रहा एक्टिविटी. अगर कोई बहुत हॉट क्लाइमेट में रह रहा है, कोई बहुत कोल्ड क्लाइमेट में रह रहा है, किसी के यहाँ सोशल कल्चरल पॉसिबल नहीं है. आई वॉज सरप्राइज व्हेन आई विजिटेड अमेरिका. हमारे यहाँ मोटापा जनरली अपर सोशो इकोनॉमिक क्लास में बहुत कॉमन है. अमेरिका में उल्टा है. वहाँ मोटापा गरीबों में ज़्यादा कॉमन है क्योंकि वहाँ फिटनेस बहुत महंगा है. वहाँ पे -40 डिग्री तक के टेम्परेचर जाता है. अगर आपको वर्कआउट करना है तो यू हैव टू हैव बाय अ मेंबरशिप ऑफ हेल्थ क्लब विच इज़ वेरी एक्सपेंसिव. तो मॉनिटरी चैलेंज, प्रोटीन कॉस्ट पर ग्राम प्रोटीन इज़ वेरी एक्सपेंसिव यूनिवर्सली ग्लोबली. सो प्रोटीन प्रोडक्ट लेना या हाई प्रोटीन डाइट लेना बोलना इजी है, लेकिन पेशेंट के लिए अफोर्ड करना मुश्किल है. देन जिम मेंबरशिप प्लस अदर इक्विपमेंट साइकिल has started from ranging from 20,000 and it has gone up to few lakhs rupees as well. So monitoring is one of the important factor. Then patient ka disease status, uska heart status, lung status, this all matters when you consider the patient not able to work out. There are some cycles, as you are all aware, कि obesity कुछ cyclical कारणों के कारण lose करना मुश्किल होता है. जैसे बॉडी में PCOD होता है, डायबिटीज होता है, ऑब्स्ट्रक्टिव स्लीप अपनी होता है. ये सब बीमारियां ओबेसिटी की वजह से आती है. और ये सब बीमारियों की वजह से बॉडी में लेप्टिन कम होता है और इन्फ्लामेशन बढ़ता है. लेप्टिन की सेंसिटिविटी कम होती है और हमारे बॉडी में एक कांस्टेंट स्टेट ऑफ इन्फ्लामेशन होता है. इंसुलिन रेजिस्टेंस होता है और ये सब बायोकेमिकल लेवल पे आपको ओबिस बनाते हैं. और आप जैसे ओबिस बढ़ते हैं बीमारियां और बढ़ते आती है. तो ये साइकिल्स को ब्रेक करना इज रियली डिफिकल्ट. So when you are assessing obesity, you have to not ask what is making this patient obese. You have to ask why. Why this patient is eating more, why this patient is not able to burn more. Is the environment a reason? Is a culture a problem? Is a biology a problem? Is a psychology is a problem? So when you know why this patient is obese, so you have to second level evaluate how this obesity is affecting this patient. Why anybody will seek a treatment unless it is not affecting them. So either it is causing them social stigma, either it is causing them mental of metabolic problem or a medical problem, or it is leading to their day-to-day routine is affected, their lifestyle is affected, and then you have to plan what is the treatment option. So when you are assessing obesity, the first and foremost thing that you have to assess is mental health. A lot of psychiatric disorder like depression, anxiety, attention deficit disorders, and other all psychiatric disorder and psychiatric medication as well, all can lead to obesity. You cannot treat a patient who is suffering from any of this psychiatric disorder or psychological disorder without treating this. You cannot make them comply with your diet plan. If you are a dietitian, if you are a physiotherapist, you cannot make them comply with your workout plan. So you have to first assess whether this patient is carrying some underlying depression, anxiety, ADHD, or any other psychiatric problem. Second is mechanical problem. Somebody have low backache, sleep disc, plantar fasciitis, or any knee pain, or any other thing which is obstructing their physical movement, and they are not able to walk. You are asking them to run 3 kilometers, but they are not able to walk 30 steps as well. Then metabolic is another problem. You have to see whether the patient is having any thyroid issue, diabetic issue, any other endocrinological problem, like I said, PCOD, diabetes, infertility, and all these problems, obstructive sleep apnea, whether your patient is snoring, is having daytime insomnolence, or uska interrupted sleep hai, all this can make your patient obese again. So all these patients of obesity have this underlying disorder and they can make them obese in a cyclical manner. So metabolic evaluation is very important. And fourth most neglected is what kind of treatment your patient can afford. If you can give them a very high fundu treatment, hiring a personal trainer, going to the very high-fi gym, or diet plan which he cannot afford. So patient can just listen to you, but will not opt for it because he cannot afford it. So you have to custom made the plan as per the affordability of the patient. So as we are go for the management treatment planning, we should know that these are all disorder, right from the depression, migraine, pseudotumor cerebral, dyslipidemia, heart attack, stroke, acidity, reflux, diabetes, polycystic ovarian disease, gout, and your osteoarthritis and urinary incontinence. All these are related to obesity directly. And if you treat the obesity, this is what is the result you can see in all this patient reduction up to 98 to 100% in few of the disorder as well. So when you evaluate your patient, you have to evaluate for all this disease. Then when you plan for the management, that is most critical. You have understood why patient is obese, what are the problem he is facing. Now you know what to address and how to address. Then when you plan for a management of this patient, what all important component a team should have, a physician or a bariatric surgeon, a physiotherapist or a gym trainer or a personal trainer who can understand the patient injury, capability, strength and weakness and plan a workout plan. A dietitian is a paramount part of the patient treatment plan, because you have to understand what kind of calories, what kind of composition mix of the diet patient is having, what quantity diet of patient is having, and what is acceptable to patient, and it has to be dynamic. It cannot be a constant thing. Then as I said, mental health is very important when it comes to obesity. You have to have a psychologist who understand patient, who help them to change their behavior, overcome the psychiatric binge eating disorder or stress or hedonic hunger, and a trainer. So generally when we plan our approach, we have lifestyle modification, then we have pharmacotherapy. After lifestyle, what else? Then you have drugs which helps you to your patient to reduce weight from 5 to 15%. Initially, we have drugs only which can help you to reduce weight up to 5%. But research have now come up with a drug where patient can lose 15% of weight with even tablets and weekly injections, subcutaneous injection like people take for insulin, and maintain it for long term. And then you have weight loss surgeries done through either endoscopy put through your mouth or a laparoscopy put through your abdomen through holes. So we'll be discussing all this. So what are our weight loss strategy? Our weight loss strategy start from the calorie restriction. What is calorie restriction? You have to calculate basic calorie expenditure of the patient, and then what active workout he is doing. Generally, a patient have 10 to 20% of the total base calorie is what he actively spending if he is a sedentary worker. Depending on the activity, you have to adjust according to his calorie requirement. How much restriction you can give? Anybody from the audience, I can see a lot of dietitian are there. Can anybody would like to answer what is the safe limit of calorie restriction that you can practice? Anybody? So generally from 300 to 700 kilocalories is what is recommended. You cannot go more than 700 kilocalorie. And if you are going more than 500 kilocalorie, then your patient has to be monitored by a physician on a regular basis. And you should not do high calorie restriction for a period more than 3 months. So 700, not more than 3 to 6 months maximum. And you have to monitor your patient for kidney function and all other things. What is safe is 300 to 500, where your patient is most compliant as well, and you can practice it safely as well. Then, as I said, you have to see what factors your patient is having, which is making him obese. You have to act on the etiology. Behavior modification, you have to target. You cannot target all behavior all in one go. You have to select 1 or 2 of his behavior, work on it for next 1 or 2 months, up to 3 months, and then keep adding the next modification only after 21 days, not before 21 days. And then while your patient is losing weight, he's not just losing fat, he's also losing muscle. So you have to add strength training to your program so that he to prevent his muscle loss. So benefits of weight loss. So even the 5 to 10% of weight loss can show significant improvement in not only lipid profile, blood pressure and diabetes, but also the heart diseases, sleep apnea and other factors. So it also alters the biochemically also your liver function, beta cell function, which secrete insulin, your muscles, your adipose tissue, everywhere the inflammation is reduced and the patient is feeling better. The problem with the lifestyle management for the weight loss. If you see, we all promise lot of heavenly result with diet and exercise, but we all know as a fact there are only 8 out of 10 patients who require additional intervention for the weight loss. It is only 2 patients out of 10 who are able to lose it in the first place adequately. Rest of the people require some or other form of intervention, not only to lose, but also to maintain. 50% of patients who has lost their weight by lifestyle modification have gained back all their weight and gone above in next when you follow them for 5 years. We all know we have success. We have 30 kg, 40 kg, 12 kg, 15 kg in first 6 months. The what after 6 months? All of your patients slowly goes back to normal and even more. And then up to in a 35 patient fail only in the first year also. So why this happen? This happens because our body is adaptable. It do a metabolic adaptation at neural and the peripheral level. It changes the your basic metabolic rate. It become more as you start restricting calorie, your body start making your function more energy efficient. For the same function, body will burn less calorie and it will start becoming energy efficient and your patient will be burning less calorie. So body adapt to your diet very fast, sooner than what you think. There is a homeostatic eating. When patient feel hungry, he eat, and there is a hedonic eating. Patient without hunger eats, and this without hunger eat can be stimulated by your neural hormones and the gut hormone as well. So this adaptation is the reason that your lifestyle modification fails a lot of time. If you see the studies done by various people over the period from 1984 to 2010 also, or 12 also, there is a significant weight loss. All study has shown during treatment phase, patient lose significant weight, up to 20 kg, 30 kg as well. But a 35% patient regain back in the first year, and gradually 5 year, if you see, the final level is above the what was the base level. So this is what unfortunately happens because obesity is a disease. We have to accept, like you require treatment for diabetes and hypertension for your life. Same way, if a patient is obese, he requires some or other form of treatment, maybe diet, exercise, some drugs or some other thing for life. So for treating all this disorder, the important thing is to diagnose this early and treat them early, because if you treat them early, the reversibility of diabetes is as high as 95%. In first 4 years of starting of diabetes, if you treat his obesity, 95% of patient will become non-diabetic. But as you delay the treatment of obesity, your patient's remission rate will go on reducing. So efficacy of the pharmacotherapy, as I said, it has start from 5 to 15%. It has changed because of the new drugs. We have endobariatrics, where we through endoscope we reduce the stomach capacity by either putting a balloon or taking few sutures, and that can also lead to the weight loss up to 20 to 25% as well. And it's a daycare procedure done under simple anesthesia, sometimes without anesthesia with sedation. It's quite safe and very effective. Then we have bariatric surgery. There are a lot of misconception about the bariatric surgery कि बहुत मोटा है तो ही bariatric surgery करना है, इसको diabetes बहुत extreme है और किसी दवा से control नहीं आ रही तो ही करना है. As I said, first 4 years is the time when you should act and make his obesity go to reverse his diabetes and other thing. So your surgery is not for only extreme patient. It is not for all patients as well. Bariatric surgery is a lifetime commitment. It requires permanent change in your lifestyle. So those patients who are not having IQ or able to understand the requirement of bariatric surgery, these are not the patient for the bariatric surgery. You cannot do more harm to this patient by doing surgery than doing some other stuff. So डिसीज से ज़्यादा ट्रीटमेंट नहीं खराब होना चाहिए, इसलिए हर पेशेंट के लिए भी नहीं है, लेकिन एक राइट स्क्रीनिंग प्रोसेस or right counseling and pre-bariatric lifestyle modification for 3 months is what is a prerequisite for a bariatric surgery as well. As I show you the lot of hormone which affects the oxygenic and anorexigenic pathway. Bariatric surgery affects not only by reducing the food intake or how the way food is absorbed into your gut, it also changes your neural axis by decreasing the ghrelin hormone and increasing the GLP-1 and P peptide. It increases the leptin level in your blood, and that is the main reason that bariatric surgery is able to keep your weight off the shelf for very long period. Even 10 years, 20 years, a lot of patients are able to maintain their weight loss, and few patients, 10 to 20% patients, do gain their 10 to 15% of weight over the period of 5 to 7 years, but still they are a lot below than their base level. As you see, only with the lifestyle modification, after 5 years, they were above their base level. So even 10 to 20% regain of weight in 7 years is still considered success in bariatric surgery, and it should not be seen as an option for the only severe and non-responding patient. It is one of the very important option for maintenance of the weight loss. As you can see, the reduction of the HbA1c, which we do for monitoring the diabetes over the 3 months, is significantly high in all these patients. And short-term result, as we are all aware, excessive weight loss in bariatric patient is up to as high as 70 to 80% in few studies and few surgeries. And it is absolutely safe option, as safe as a lap cholecystectomy, which is most commonly done laparoscopic surgery. That is what is proven by statistics. So here what I propose that it's a multimodality treatment. We have to not see obesity as a weakness or any social problem. It is a problem of a disease, your genetics, and a multiple other factor or metabolic factor which is making your patient obese. And losing weight is not just the important criteria. Maintaining it is the most important criteria. You should definitely start with lifestyle modification. You should have a workout plan, because it is most important thing for long-term success for any treatment plan. But once the patient is not able to maintain it, you have to identify it and start them on the medical or surgical treatment, which is more appropriate for the patient. Even the 10 to 15% weight loss make hell lot of difference in his disease profile and his day-to-day life. So we should give them their best chance in the initial year of their disease, rather than to wait when the disease become 10, 20 years old, he has damaged his kidney, he has damaged his heart, and then act and then achieve a substandard result. Thank you.